Good afternoon. My name is Nargis Farahi. I'm a family physician and the Director of Maternal Child Health Services at the UNC Department of Family Medicine. I'm also serving as one of the clinical champions for our perinatal region, Region 4. Today, I will be sharing a little bit about implicit interconception care, a model for improving birth outcomes through interconception care at wellchild visits. I hope that I will be able to engage others in thinking about how we can use wellchild visits as an opportunity to improve maternal health and the health of the entire family. I think it's important to start with our why. Why would we want to take time in a wellchild visit to focus on the health of the mother? So these are the problems at hand. Preterm birth and birth defects remain unacceptably high in the United States, and maternal mortality is rising. Every year, 700 women, or almost 2 women a day, die because of pregnancy-related issues, and 24,000 babies die before their first birthday. Although early and adequate prenatal care is important, it has not been successful alone in reducing low birth weight and prematurity. At the same time, we know that there are many modifiable risk factors for poor birth outcomes that are present prior to pregnancy. And with almost 50% of pregnancies being unintended, there are not opportunities to intervene and improve these risks if we only use planned visits from others. In the postpartum period, we know mothers often ignore their own health while they bring their children to many doctor's visits, especially wellchild visits in those first 2 years of life. This is the March of Dimes preterm birth report card for the United States, and we're going to zoom in to North Carolina. North Carolina there in the yellow means that it's receiving a D+ grade for preterm birth, with a preterm birth rate of over 10%, and you can see it's been ticking up over the last 6 years. If we look closer by race and ethnicity, we can also see that the preterm birth rate among Black women is 46% higher than the rate among all other women in North Carolina, with no improvement from prior years. Looking at social drivers of health, we can see that compared with the United States more broadly, women in North Carolina face higher rates of poverty and lack insurance at higher rates than their counterparts across the country. So with that background, I'm going to talk a little bit about the Implicit Network. Implicit stands for interventions to minimize preterm birth and low birth weight infants using continuous improvement techniques. The Implicit Network was developed as a learning collaborative to improve the health of women, birthing people, infants, and families through innovative models of care and quality improvement. This collaborative was established in 2003, and its initial work was with quality improvement initiatives during pregnancy, like the 39-week project, to try to improve birth outcomes with improved prenatal care. As we've discussed, there are limitations in the amount of improvement that you can gain by only intervening during pregnancy. And so the current work has a focus on interconception care, with future work focusing also on the 4th trimester. The vision of the network is to help create a future where all mothers and birthing people are fully supported to attain optimal health and wellness for themselves and their babies. The network now spans 8 states, including North Carolina, and has now over 30 sites total. So now that we've learned a little bit about the Implicit Network, I'm going to talk more about the implicit interconception care model. The rationale behind this model is that mothers bring children to wellchild visits, though they may not seek care for themselves. Additionally, mother's health and behaviors directly impacts not only her health, but also the impact impacts her children's health both positively and negatively. Examples of this include tobacco use and depression. And so in caring for children, it's essential to care for their mothers as well. From studies that have asked mothers, we also know that women accept inquiry and advice about their health at pediatric visits, even if it's by a provider who is not their own. So with this background, the implicit interconception care model was developed with the idea to focus on 4 behavioral risks affecting future birth outcomes during the wellchild visit. These 4 domains are smoking, depression, family planning and birth spacing, and multivitamin use with folic acid. In the first domain of smoking, we know that 20% of smokers quit during pregnancy, but 70% of those who quit will relapse within 6 months postpartum. Wellchild visits are an ideal place to assess maternal smoking status and provide evidence-based intervention like smoking cessation counseling using the 5 A's techniques. Similarly, with depression, we know that symptoms of depression are really common in the postpartum period. And for those whose depression has been treated or in remission during pregnancy, there are high rates of peripartum recurrence. By screening for depression in wellchild visits, there are opportunities to detect recurrent or untreated depression and connect women with services. In the third domain of family planning, we know that unintended pregnancy and short interpregnancy interval increase the risk of low birth weights and prematurity. Antenatal counseling does not show an increase in postpartum contraception use, and many women miss their postpartum visits. Wellchild visits may be an opportunity to address reproductive life goals and connect women with services at a time when they're more ready to make plans and accept this advice. And the fourth domain within the implicit interconception care model is multivitamin use. We know that routine folic acid use reduces the rates of neural tube defects by 66%. And multivitamin use with folic acid is associated with additional benefits for improved birth outcomes. That being said, only 24% of US women use prenatal vitamins with folic acid, and less than 20% know that this is recommended universally. So in the implicit interconception care model, the goals are to repeatedly screen for these 4 behavioral risk factors at every wellchild visit from birth to 24 months of age. This includes assessing for these risks, reinforcing desired behaviors to optimize maternal health outcomes, connect patients with primary providers or community resources to address risks, provide prescriptions or free multivitamins as needed, collect and analyze data to drive improvement, and develop strategies to improve care, delivery, and patient outcomes. I want to share a little bit of data from the Implicit Network. The network really focuses on quality improvement using strategies like plan, do, study, act, with repeated cycles of improvement and change to learn from prior attempts and really try to make this process as seamless and as patient-friendly as possible. From over 100,000 wellchild visits that have been captured within the implicit sites, we know that 95% of these visits are attended by the child's mother. The sites that are participating in the Implicit Network are caring for a diverse patient population, with 42% of the mothers surveyed being Black and 12.5% identifying as Hispanic or Latina. Additionally, the patient population is largely on Medicaid or self-pay and has not attained high levels of educational attainment. In well-child visits that have been screened and reported to the Implicit Network, there are high rates of positive screens, with the most common one being lack of multivitamin and folic acid use, followed by lack of contraception, smoking, and then depression. And within these over 75,000 well-child visits, interventions are provided when there are positive screens at high rates across the network. So I want to provide an example of how the screening and intervention may be making a difference. So looking at the next slide, we're going to be looking at unique mother-child dyads, with the first column representing those that had a positive screen, and the next column showing if there was a change in that screen from one visit to the subsequent visit. And you can see here the rates of positive screens for smoking, depression, and contraception, multivitamin use, and then see that there were significant changes with interventions provided from one visit to the next. Looking at data can be helpful, but I think sometimes just sharing a personal story from a patient can help illustrate the impact that an intervention can have more clearly than looking at the graphs. So I want to share the story of a mother who I cared for a couple years ago, who presented with her child for the 9-month well-child visit. At that well-child visit, we did the implicit interconception care screening, and all 4 screens were positive. She had quit smoking during her pregnancy, but had restarted smoking within a couple of months of birth. She had stopped her birth control pills because she was having some side effects, but she really did not want to become pregnant in the next year and was concerned about her risk for unintended pregnancy. She screened positive for depression, reporting increased stress at home, and she had been taking multivitamins after pregnancy, but had stopped those as well when her prescription ran out. So that same day, we provided her with multivitamins with folic acid right there in the clinic, provided her with some supportive counseling, and connected her with our behavioral health specialists for assessment and support. I did a brief intervention for smoking using the 5 A's technique, and she was interested in nicotine replacement that we were able to prescribe for her. And we discussed her reproductive life goals, and she was really interested in a long-acting form of contraception, and decided she would like to schedule an appointment for a Nexplanon placement. So I saw her back in 2 weeks to follow up for her depression, and continue to see her along with our behavioral health counselors after that. And then we were also able to perform a Nexplanon placement at that 2-week follow-up. At the 15-month well-child visit, all these screens had changed. She was no longer smoking. She had a contraceptive method that she was happy with, and was in line with her reproductive life goals. Her depression screen was negative, and she was now taking multivitamin with folic acid. So going back to the implicit network data, to summarize, we know that mothers attend many of their child's well-child visits. And so this is an opportune time to screen for health issues that impact both the health of the mother and also of the infant and other children. We know that these modifiable risk factors were successfully identified during brief screenings, and mothers screened positive for one or more behavioral risks at 63% of visits. Without interconception care, many mothers would likely receive no additional care to address these risk factors. And with this brief screening and intervention, change was seen over time. Women continue to screen positive for behavioral risk despite high intervention rates, with women often developing new positives. So maybe their depression has improved, but then they may resume smoking or come off of a contraceptive method. And so additional strategies are needed to think about how best to use well-child visits to both kind of educate and support mothers and make sure that their care is really in line with their goals. In summary, interconception care is a brief, innovative, sustainable model that can be used to improve maternal health as well as the health of families and future pregnancies. So let's think a little bit about how the implicit interconception care model can be implemented. Like so many other things, an essential component is really building a team. One key component is really developing workflows. So providing the screening questionnaire, whether it's in an electronic form or on a sheet of paper, is pretty simple to do, but it's really important to think about how this is going to be done in the clinic to make sure that it's done consistently for each visit and each patient. You can see here an example of an interconception care workflow from MAHEC, really starting all the way from the kind of front desk staff, nursing, and then coming down to the role of the medical provider. And prior to implementation, it's essential to have a plan for how positive screens will be addressed. So, especially if a mom is not a patient, thinking about referrals that are needed or kind of networks that can be tapped into are essential. And engaging care management as well as behavioral health can be really helpful. Things like suicidality that may come up on a depression screen can be an emergency. And so having a plan in place for the rare times when this does happen is really important so that providers and the whole clinic team is prepared for those circumstances. For each positive screen, there's really a spectrum of intervention that can be provided from the least intensive to most intensive. And so also kind of thinking through the types of interventions that can be provided and the time needed to provide them, and the person on the team best suited to do that can be really helpful prior to implementation. Patient education to accompany the screening can be really helpful and can really help with patient kind of buy-in and excitement about the screening as a part of their child's care. So this is an example of a sample workflow, and you can see here that if the patient has previously smoked cigarettes or is currently smoking, there's then a workflow for the different ways that that could be addressed. Having free multivitamins with folic acid or prenatal vitamins in the clinic can reduce barriers to going to the pharmacy to get these. And sometimes funding can be obtained through the health department or March of Dimes to have these available in clinics, not just for adults, but also for children. having data collection tools can really help with knowing how effective your implementation strategies are and doing those cycles of quality improvement to make sure that you're really achieving what you're setting out to achieve. The great thing about being a part of the Implicit Network is that sites have already developed EHR templates for Epic, Centricity, Allscripts, and these can often be adopted and implemented in new settings without the need to reinvent the wheel. This is an example of one of these in Epic. And then for people who want to really engage and share the data from their clinic with a larger network, there's the opportunity to do that with a larger data management system to really see how your local findings are similar or different from what's seen at other sites, and to learn from those other sites and kind of share your findings as well. And at the kind of very core, the Implicit project was started as a quality improvement project. And so there are always ways to improve processes for screening, as well as addressing positive screens, for providing patient education. And so having this be a part of the quality improvement work that's already happening in the clinic and integrating with existing quality improvement teams can help make sure that this is more successful rather than being a siloed project. For sites that are interested, this is a kind of model checklist for implementation. And this is really kind of a summary of what the Implicit Network can provide to help implement interconception care in visits. If you're interested in learning more, there's information about the Implicit Network through the March of Dimes, as well as through the Implicit Network website. And I'm happy to help address any questions and work kind of individually one-on-one with any providers or clinics who are interested in implementing this at your sites. Thank you so much, and please don't hesitate to reach out to me with any questions.